Okay, so I know that pharmacology can be very daunting, okay? I know that it can be a lot, okay? But I want to reiterate that it's not just memorization, okay? You need to be able to apply what you're learning about each drug, okay? Why? Because when you go to the bedside, you need to understand why your patients are getting these drugs, okay? You are not a robot, right? You are a nurse who uses their critical thinking, and you need to understand why they're getting something, okay? And you could have the responsibility of titrating multiple drips, so you need to understand what you expect, right? So what I titled this is what to expect, and these are some questions to guide your study. Now, the thing that people always ask me, right, is do they need to memorize dosages? Okay, everybody always wants to know that. And I say, no, you do not need to memorize them. Why? Because when you have a MAR at the bedside, they are always going to give you the dosages and the MAR and what to titrate to, okay? However, there's always a caveat, you know that. The caveat is that when you are doing your math problems, okay, when you're doing your math problems and you do your dosage calculation and you get an answer of 300 mics per minute of epinephrine, that is not the right answer. I'll tell you that right now, okay? Because we generally do not run epinephrine. Oh my gosh, that's so nice. Okay, thank you. What?
That's why we were late.
That's okay, but I'm so glad you guys got through. That looks delightful. What is that? It's a what? Oh, no. I'm okay. I'm just curious what it is.
It's a bagel.
Like a jalapeno bagel? Yeah. Oh, you guys, it's so fun. I love that. I'm a bagel girl. I don't really like donuts. I know that's weird. Whatever. I also don't like cake. I know, also weird. Okay, so dosages. We were talking about pharmacology, okay? And the dosages, I do not want you to memorize them. Why? Is because on your MAR, you will have access to that. You will have access to your max rates, your max dosage of stuff, okay? However, I need you to understand and be familiar with the ranges, okay? On the test, I'm never gonna ask you what the range is, okay? I'll tell you that right now. However, as a check and balance, okay, if you do your math problem and you get the answer of 300 mics per minute of epi, that is not the right answer. You need to go back and figure it out, okay? Because you should never get 300. So it behooves you to be familiar with the range, okay? But I'm never gonna ask you a question and say, tell me the range of propofol. What is the dosage, okay? Does that make sense? Because that information will be on the mark. What do you say?
That would fall into too if you get some like erroneous order that the doctor would be paying attention to the dose.
Totally, 100%. Yeah. Totally. Remind me when we get to propofol to tell you a story that just happened a couple weeks ago with that. Because it does happen. And so obviously, you know, for testing purposes, right, because you guys all care about that. You want to proctor points. So yes, 100%, I'm never going to ask you a dosage question in that regard. Tell me what the dosage of epinephrine is, okay? But for your math purposes, checks and balances, you should be aware, at the bedside, you are totally accountable, okay? You are totally accountable to knowing what your max rate is, okay? What your minimum rate is, and then how you're titrating it, okay? That's in the order. You have the capability of looking at that, so it's not something necessarily need to memorize. I kind of recommend that you should memorize it at the bedside, okay? But you are accountable to knowing that. Does that make sense? Okay. So again, real world versus nursing school. I'm not going to ask you on the test for that, but in the real world, you better know what you're titrating your drip to, okay? Okay, so here is some questions to kind of help guide your study, okay? I think it's important to understand what type of patient you are giving this drug to, with whatever it is, okay? And then your test, your pharmacology test, is going to be geared around what do you expect. So what do I mean by that, okay? Is when you start a drug, what do I expect to happen? How do I know that it's working, okay? That's what we're gonna talk about today. So again, what do you expect, right? Yes, I need to understand what the drug does, but I need to understand clinically when I look at my patient, oh, it's working, great, fabulous, okay? Does that make sense? And then we also want to make sure that you understand what the side effects are, and then the nursing considerations that we'll talk about, okay? Make sense? Kind of? Clear as mud? People always say that expression. It's kind of my least favorite. Okay, so let's talk about this clinical scenario. So, 65-year-old male admitted for respiratory failure related to COVID-19 and pneumonia, okay? Patient is intubated and being mechanically ventilated. The patient is adequately, okay, interesting, you see how I've underlined that and italicized it, bolded it, okay? Adequately sedated on a propofol infusion. So real quick, propofol, why do we use propofol? It's a sedative, exactly, okay? So again, this is not a test, you guys. On both of your windows, you have your Nearpod, and then another window, you should have your soft chalk open, so you can refer to it, okay? Yes, we're gonna go through this, okay? We're gonna talk about it, but you have the answers all at your fingertips, okay? So propofol is used for sedation, and they also are on a fentanyl infusion, which is for what? The answer is right there. For analgesia, for pain, right? So again, two different infusions are going, propofol and fentanyl, okay? And we know that the patient is on whatever dose they're on and they're adequately sedated, okay? So the patient is becoming progressively hypoxemic and febrile, okay? So that means that they're laying in the bed, they're not really moving, they are at a beautiful RASS, which we'll talk about, Richmond Agitation Sedation Scale, okay? Let's say they're at like a -3 or 4, okay? But they are desatting. You look up at the vitals and they're desatting, SATs are in the 80s, okay? You take a temperature and they're febrile, okay? So you think to yourself, well, maybe they're hypoxemic because they're febrile, right? We know that being febrile can drop someone's oxygen SATs, right? So I'm gonna give Tylenol. So the RN gives 650 milligrams of Tylenol, but unfortunately, nothing's happening. They're still like 39 degrees. So sad for us, okay? The patient is placed on a cooling blanket because you can't just leave them at 39 degrees, right? So we got a whole host of problems. But let me reiterate, the patient is adequately sedated. They're not waking up, they're not moving. The hypoxemia is essentially being driven probably by the fever, okay? So now, we're really sad because you go in and you're like, dang it, we're still febrile, and then the patient, no one likes a cooling blanket, right? They're uncomfortable, starts shivering. So now you're like the most sad, right? And then you look at the freaking ventilator and that starts alarming. So your day is like literally going down the toilet, okay? You wanted to go grab lunch, but now these things are happening and you can't leave, okay? So your alarm, your high pressure alarms start to go off on the ventilator, which is signaling that now the patient's desynchronous, meaning that they are fighting the ventilator. They are not allowing the ventilator to do the work of giving the adequate breaths. They're probably tachypnic and they're not getting the adequate volumes, okay? So now we have a multifactorial problem. They're febrile, they're shivering, and now they're fighting the ventilator, okay? And the result of that is that they're desatted. They are hypoxemic, okay? You guys following? Yes? Okay. So, what are you gonna do about this? What do you guys want to do about this? What do you think?
Call the nurse.
Call the nurse? You're the nurse. You're the nurse. What are you gonna do?
Call an adult nurse.
Sure. Phone a friend, right? Phone a friend and be like, my patient's not doing well, right? My patient's not doing yes.
Suction, see if there's anything blocking.
Okay.
Maybe give them a O2 breath to catch up.
Okay. So that could absolutely work in the interim, right? So maybe they're desynchronous on the ventilator because there's secretions, and maybe in the interim you get it, but there's nothing. You suction them, there's nothing. You go to them, so it goes up to 90, but that's short-lived, right? Because remember, what's driving the hypoxemia? The fever, right? And you're trying to treat it. Tylenol did nothing, which happens sometimes. So they're on the cooling blanket, and that is causing the patient to shiver. Now, when someone is shivering, what is that doing to someone's oxygen consumption?
Going up.
It's going up, absolutely. Okay, so the patient's already sick, they're fevering, which means that their oxygen consumption is already high, and now they're shivering, which drives it even higher up, okay? So now we're very sad, and we're like, uh-oh, what is happening? And we can't even increase sedation because my patient is adequately sedated. So we're up a creek. I don't know, we gotta phone a friend and figure it out. These are our vital signs in our labs, okay? So going through the vital signs, heart rate of 127, high, low, or normal? It's high. Okay, so tachycardic, right? Now, at the very least, looking at the story that I just presented to you, the clinical scenario, what is driving that tachycardia? Remember, there's always a reason why. Why are they tachycardic?
If they're febrile, maybe they're dehydrated.
Okay, so they could be dehydrated, but let's focus on the fact that we know they're febrile, right? We know they're febrile, okay? Also the fact that they are breathing fast, right? With a respiratory rate of 34, okay? And then they're shivering, okay? So we know that heart rate is high. What about that MAP of 61? Do we love it? Do we hate it? We kind of hate it, right? Is it adequate? Yes, Eduardo.
In block 3, they
Yep.
told us that the map, or was it block 2? I don't know, the map was 60.
Okay.
Low, but they're saying it's 65.
I totes, I'm saying 65, yeah, totally. So again, it depends at the bedside, right? I've had lots of patients where the physician says a MAP of 60 is okay. I've had instances where people are like a MAP of 55 is okay. For my class and this particular time that we are together, I would like a MAP of 65, okay? So if you have a MAP of 65, you know you have end organ perfusion, okay? When you get to the bedside, please ask your physician, what is my MAP goal, okay? I think that is adequate, but know that what's loosely based is 65, okay? So a MAP of 61, is it adequate? No. Okay, so it's low, right? And then a pulse ox of 84. High, low, or normal? It's low, right? We just talked about that. We talked about how the patient's hypoxemic and they're desatting. So a sat of 84 is not kosher. We do not like that. We need to do something about it, okay? And then a temp of 40. Woo! You're cooking. Is that something that we love? No, okay? We're trying to do interventions, right? We put them on the cooling blanket. We gave them Tylenol, but they're still febrile, okay? Let's talk about that gas. What do we think about the gas? Okay, so let's go through each. pH 7.20. High, low, or normal? It's low, right? Normal pH is 7.35 to 7.45. Remember when I said you're going to be seeing ABGs every single class? I didn't lie. This is what we're doing, right? So pH of 7.2 is low, okay? So right there we can say that the pH is acidotic or alkalotic? Acidotic, exactly, okay? PaCO2 is 65. High, low, or normal?
High.
It's high, okay, perfect. Normal PaCO2 is 35 to 45. We have 65, okay? PaO2 is 55. Slow, okay? Which correlates with what's happening, right? Because we're desatting, so I would anticipate that to be low because we're hypoxemic. Bicarb of 24. High, low, or normal? It's normal. It's great. Good. Perfect. Okay. And then a SAT, of 76. It's bad, right? A SAT of 76 is bad. So we got to do something about it, right? What would we classify that ABG as? So we know that it's acidotic, so respiratory acidosis. Respiratory acidosis, okay? When I learned ABGs years and years and years ago, I learned the Rome method. I don't know how y'all are learning it, but Rome, right? Respiratory is opposite, so the arrows are opposite, and then metabolic is equal. What I mean by that, are you guys familiar with that way to decipher it, right? So you always look at your pH. Is it an up arrow or a down arrow, right? And then respiratory is opposite, so pH is down, CO2 is up. So I know it's respiratory acidosis, okay? If you don't want to go that way and you didn't learn that way, please don't let me confuse you. But the take-home message for this is you need to be able to distinguish what an ABG is, okay? Whatever method you do, you need to be able to do that, okay? So is this something that I love? Is this an ABG that I'm cool with leaving my patient? Can I go to lunch? Absolutely not, right? I'm not calling the doctor and being like, yo, we got a problem, we gotta do something, okay? So, what are we gonna do? We are going to do a neuromuscular blocking agent, okay? So we talked about it, right? We talked about it. Our patient is fevering, okay? They're hypoxemic. We're trying to cool them, but we're shivering now, so our oxygen consumption is through the roof, okay? And on top of that, it's like, you know, the story that never ends of the debacles, right, is that we have respiratory acidosis. Our ABG sucks, okay? We are adequately sedated. You cannot give that patient any more sedation because they're sedated, okay? What's happening is that oxygen consumption is being driven by the fever and the shivering. So we need to do something to help that, okay? So we can anticipate that we need to start a paralytic, also known as a neuromuscular blocking agent, okay? How I will be referring to them in class is a paralytic, just because it's easier to say. But know that a paralytic is synonymous with a neuromuscular blocking agent, okay? So paralytic, okay? These are the types. We have rocuronium, succinylcholine, and vecuronium. The most common one that we see for a drip form is the cystocurium, also known as Nimbex, okay? So people always ask me also about the brand and generic name, right? Oftentimes, I'll be honest, I choose the one that's easier to say. I'll be honest. So like propofol is easier to say than diprovan, okay? Levophed is easier to say than norepinephrine, okay? Nimbex is easier to say than cystocurium. Rocuronium is fun to say, so I always choose to say rocuronium, okay? So I would advise you to be familiar with both, okay? When I first came to Banner, you know, I'd been a nurse for 5 years, and so I felt like, you know, I had some experience. I knew how to be an ICU nurse. And the physician came in, and her name was Roxanne Garcia. Loved her. If I was sick, I'd absolutely want her taking care of me. However, she was one of the most intimidating physicians I've ever encountered, okay? We called her the tornado, because she'd come in and like change 500 things, and if you weren't paying attention, you didn't even know what was happening, okay? So she came in my room, this is like, I don't know, day 2 off of orientation, and she's like, I need you to start Dobutrex, and walks away. And I'm like, Dobutrex? I'm like, what the heck is that? I was like, okay, and then she comes back and she's like, yeah, did you start it? And I was like, dude, you just left, like, seriously 5 seconds ago. I'm still in the room, right? And so I didn't know what that meant. I was like, Dobutrex. I was like, what is that, right? I go to the Pyxis, I like type it in. Thankfully, the Pyxis does both names, but it was dobutamine. I had never used that. I'd always known dobutamine, okay? But she uses Dobutrex. So the point of this story, okay, is to understand what your physicians use, okay? Understanding they may do other names, okay? They may choose to say the brand name. They may choose to say the generic name, but it behooves you to understand both, okay? Does that make sense?
So what happened?
Oh, she like was mad at me that I hadn't started it yet. And I was like, I gotta go grab it. And then in my head, I'm like, what the heck is Dobutrex? So again, I figured it out, right? I went to the Pyxis, and the Pyxis helped me out, where I typed that in, and then dobutamine came up. But it just was a good lesson to know. And then diprovan, she always said diprovan. She never said propofol. Same thing. I was like, diprovan? I'm like, what the heck is that? Propofol, right? So all the physicians in flag used propofol. They didn't use diprovan, right? They didn't use Dobutrex. They used dobutamine. So it is important to understand both of those names. At the bedside, we say Levo, which is also Levophed, right? I very rarely hear norepinephrine. Okay, does that make sense? Okay. So going back to this, right? So the cystocurium, also known as Nimbex, is oftentimes what we use at the bedside for a continuous strip, okay? A continuous strip. So what does it do, right? It's a neuromuscular blocking agent. Do I want you to memorize this? It's a non-depolarizing, blah, 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 all that stuff? No, okay? What I need you to understand, it's a paralytic, okay? It is going to paralyze the skeletal muscle, okay? It's going to paralyze the skeletal muscle. It does nothing to your smooth muscle. So your vasculature is gonna work, your heart's gonna work, your diaphragm maybe will be affected, hopefully a little bit. And then most importantly, your pupils will still constrict, okay? It does not paralyze your pupils, okay? It just works on your skeletal muscle, okay? So this is the action of what it does. Blocks the cholinergic receptors, blah, 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 muscle paralysis results, okay? So why? Why are we using a paralytic? Well, we already talked about this patient is adequately sedated, right? He's got propofol going, he's got fentanyl, his RAS we are achieving of a -3, we are golden, but he's still hypoxemic, okay? Our ABG still sucks, so we need to do something about it, okay? So what can it help us do is it can help the patient become more synchronous with the ventilator, okay? So remember we talked about that, the patient inadvertently was desynchronous with the ventilator, it was fighting it. Okay, it was tachypnic, we weren't getting our volumes, which was what was driving that bad ABG, okay? That's why the patient had respiratory acidosis, okay? So it can help make sure that we give the ventilator complete control over the ventilation, okay? Airway and ventilation. And then it can also help control shivering because we're paralyzing the smooth muscle. The skeletal muscle. And then it's reducing the oxygen demand. So remember we talked about that. Those keywords of oxygen consumption were through the roof, right? And so a paralytic can normalize that, can decrease demand, okay? Why? Because we're stopping the shivering, okay? It can help the cooling blanket do its job of cooling the patient, right? Does that make sense? Okay. We'll talk more about this. So why I put this up here is because rocuronium, as well as succinylbecuronium, all three of those, okay, can be utilized either as a push dose, like an IV push, or they can, I don't think I've ever seen a succinylcholine drip, to be honest, but you can also have an infusion dose, okay? So why am I saying this? Is I need you to understand that there's two different routes, okay? One is an IV push, and one is an infusion. It depends on what you're doing, okay? It depends on why you need it, okay? So, am I needing you to memorize this? Absolutely not. Please do not memorize that, okay? Do I need you to understand that there's two different dosages for two different routes? Absolutely, okay? And two different purposes, right? So oftentimes when we intubate someone, we need them to paralyze, right? We need to paralyze them so they don't resist us putting a tube down their trachea, okay? So that's gonna be an IV push. I would say that 90% of the time, okay, we use rocuronium. That's the most common, okay, for intubating someone. During the pandemic, we ran out of Nimbex, and so then you did see a lot of people on a rocuronium continuous infusion. Nowadays, the only continuous infusion paralytic that you will see is the cystocurium, also known as Nimbex. Okay? Nope. Paralytic. So, that brings up a great question, and we'll talk more about this, but would you want to be paralyzed and awake?
No.
It's actually my greatest fear, you guys, to be honest. I have a lot of fears.
Sleep
That's at the top.
And you're like,
Totally, right? A dream, right? I know.
You can definitely
It's
get
the
sued
worst.
if you do it opposite.
What?
You can get sued if you do it the other way. If you paralyze before sedate.
Yes. So, yes, you should not do that, 100%. Yeah, you should not do that. During COVID, there was different things, but I'm not going to get into that. I would say that you're only going to get sued if something bad happens, to be honest. But the proper way to give this is to sedate someone and then paralyze them, okay? How I remember that is, do I want to be paralyzed and awake? Absolutely not, okay? So remember when I first said in that clinical scenario, they're adequately sedated, okay? You better believe before you start a continuous infusion paralytic, they're adequately sedated, okay? And then when you're intubating them, you are giving them a sedative and then doing the paralytic, Okay, there's very few instances, like in one instance we mixed both. You're not supposed to do that, but it was during COVID and they were gonna code, and so we had to make sure they were paralyzed and then sedate them like at the same time. It wasn't a great situation. That would be the only instance that I would say that we would ever essentially give the paralytic first, okay? Most of the time, it's sedative and then paralytic, okay? So this is an example of what you would see, okay? Vecuronium and succinylcholine are other things. Now, vecuronium is the drug that, did you guys hear about the Tennessee? I think her first name is Rhonda, the one that lost her license because she confused vecuronium with Versed.
Mm-hmm.
So the interesting thing about that is that vecuronium, it comes in a powder form. You have to reconstitute it. So maybe she wasn't familiar with Versed. She thought you had to reconstitute Versed, but it has impacted our countrywide, our practice. So anytime I take out a paralytic, like I can overwrite it in the Pyxis, every time I have a prompt that says, is your patient intubated? Or will they be intubated, okay? Because of that practice error. So she was taking her patient to MRI. She thought, okay, this patient is awake, walkie-talkie like me. Patient was, I think, anxious or whatever, needed to lay still during the MRI. So she got an order for Versed, okay, also known as midazolam, another example of knowing both, right? She pulled vecuronium instead of Versed, okay? Again, interesting, you have to reconstitute that, so I'm not sure where the disconnect was. She gave vecuronium, which is a paralytic, okay, instead of Versed, and her patient obviously stopped breathing, okay, and coded it and, died basically in an MRI machine, okay? So when you give a paralytic, you must have either be intubating someone or a definitive airway. Alex, you okay?
Yeah.
Okay. Questions, comments, concerns?
No, I'm good.
Nothing to add? Usually when someone's laughing like that, there's always something to add.
I don't understand how you confuse the two, but yeah.
It is hard. It is hard. I question as well. But again, it behooves everyone to realize the seriousness of our job. Okay? It is serious. Okay? You will make a mistake. I know you will. Okay? I have made a mistake. Hopefully, it's a fence post. Okay? It's a fence post to make sure you take a step back and you understand the seriousness of us giving medication and having control over it. Okay? Because it's us. Nobody else is there. Okay? It already has gone through the order of the physician. It's already gone through pharmacy checks. You are it. Okay? And I think that it's crazy. It's crazy to me that happened. But I think that it's even crazier that there was stops that she didn't stop and say, like, this is weird. Why am I reconstituting this? I didn't check the MAR. She didn't scan it. There's lots of things that we have checks to do. Okay? I've been an ICU nurse for 15 years. You better believe that I have a wow in the room and I'm double checking, triple checking what I'm giving. Because I am paranoid about messing it up and killing my patient. Still, I've been doing this for a long time, okay? But I still think that it is so serious, okay? When I push drugs, there's 3 things I'm looking at still to this day. I'm looking at the patient, I'm looking at my vitals, and my watch, okay? Protonics, I still push it slow, even to this day. I know people that slam it in, but I've had a bad instance where I pushed a little bit too quick and I made someone drop their heart rate, okay? So you have those fence posts. They were fine, but it makes you double check and, whoa, what am I doing? What am I doing, okay? Does that make sense? So, rocuronium, you need, the take-home message here is you need either to be intubating someone or already have a definitive airway, okay? And they need to be sedated. So, we started that paralytic, okay? Let's say we started rocuronium. And these are the expected results. So how do I know the paralytic worked, okay? How do I know it worked? So they're no longer shivering. That component of oxygen consumption, I've knocked it out, okay? They are synchronous with the ventilator. The freaking ventilator isn't alarming anymore, thank God, right? We hate alarms. or I hate alarms. It's like a triggering thing for me. So the patient is allowing the ventilator to do all of the work, okay? No more high pressure alarms, I just said that. And then the consumption, we've decreased the oxygen consumption and the patient is no longer hypoxic. And then our vitals and our ABG correlates with that. Look at our vitals, aren't they beautiful? You have a heart rate of 98, high, low, or normal? Normal, okay. I still have my MAP, which is not great, so I might have to do something about that later. But my respirations are better, they're 24. My pulse ox is finally above 90, yay for me, 95. And then I have a temperature that is lower. They're no longer febrile, 37.8, okay? And then my gas. Is my gas normal? Almost, okay? Yes, this is a little bit high.
Definitely a lot better.
Yes, this is a little bit lower. Would I like this 80? Absolutely. However, my pH is normal, okay? My pH is normal. So adding my paralytic worked, okay? So this is how you should be studying. You should understand what the drug does, and then when I start it, what do I expect to happen? Okay? Questions? Okay. Be aware of the side effects, okay? You do not want someone to be on this long term, okay? You start it for whatever reason, okay? And hopefully you're gonna get it off as soon as possible, okay? Because we know that the longer you're on it, the more tolerant the patients are gonna become, which means that you're gonna require larger doses, which is not good. And then prolonged use can cause muscle weakness and disuse atrophy syndrome. I mean, being in the ICU bed can cause that, but certainly the paralytic for sure. Okay, so nursing considerations, okay? What kinds of nursing considerations are needed when infusing a paralytic? Take a couple minutes and think about it, okay? Think about that your patient is completely vulnerable to the environment, okay? That's what I want you to be thinking about. So what kinds of things do you need to be worried about when they're on a paralytic? So take a couple minutes and do that. Has everyone signed in? Well, they're intubated, so they better be intubated, because if not, you just killed your patient. Nobody wants that. Ding, ding, ding. Good. I'm down for that. All right, let's talk about it.
Put them there so other people.
Okay, so the patient is totally susceptible to the environment, right? So the first thing that you need to consider, which we already talked about, right? The first and one of the most important things, or like probably two most important, right? Is that the patient has a definitive airway, right? You're either utilizing that paralytic IV push vecuronium, succinylcholine, or rocuronium, and you're intubating them for whatever reason, right? They have respiratory failure, they are going to the OR for a procedure, whatever reason, you need to be able for them to relax everything right here so they can shove down an ET tube down their trachea, okay? If not, people will fight it, it's just not a good thing, okay? So you need a definitive airway. The second most important thing, or maybe it's like up there, right, even, is they need to be adequately sedated, okay? No one wants to be awake and paralyzed, okay? If you do that, I will come back and haunt you. Like, that is absolutely ridiculous. I think there's a movie about it, actually. I refused. Kevin wanted to watch it, and I refused. So I was like, this is my greatest nightmare. I will not watch that, okay? It's the worst, okay? And you have people, remember that when you have someone that's intubated and sedated, they can still hear you, okay? They can still hear you. So please, please, please make sure that you are still telling your patient what you're doing, okay? Because you don't want to have them come back, okay? We had people come back, especially when they were cannulated for ECMO. It's lovely that they survived and they're living their lives. However, it is not okay when they say, I remember you, and you did things without telling me, okay? You don't want them to say that, okay? And people have, right? You want them to remember. Or you don't want them to say, hey, I remember it was really scary. It was like I was in locked-in syndrome. I was awake under the paralytic, okay, but I was paralyzed. How scary would that be, right? So it is your job to make sure you're adequately sedated. I've had to stop physicians before, and when they've said, hey, can we give a paralytic? I'm like, whoa, we gotta give some more sedation. What would you like to give? Okay, I had to do that last week. We had a patient that they were gonna do a TEE on, transesophageal, echocardiogram, where they're gonna, shove down a ultrasound down their esophagus to look at their heart, okay? And they wanted them paralyzed to not have any sort of resistance, and I knew the patient was not adequately sedated. And I was like, I will be happy to grab the paralytic. What sedation would you like? Okay? He's like, well, he's on propofol. Oh, I know, but he's not adequately sedated for a paralytic. Okay, so make sure you are that advocate, okay? Let's see, what else? Intubated, okay, so vital signs, all important. How paralyzed are they? Do I need to increase or decrease the drip? Okay, so how do we know that we're paralyzed? Okay, so that would be something that we need to make sure. How are we titrating the drip? We're gonna talk about that. It's called the train of 4, okay? But in the interim, I like monitoring vital signs. How about skin? Oh, I see skin on there, okay? So is the patient turning themselves? Absolutely not, right? They're very sedated and paralyzed. So it is your job to prevent any sort of pressure ulcer, so you're turning them. Remember, the patient is totally susceptible to the environment, okay? Are they, do you think, able to have a bowel movement easily? Why not? Why do you think they might have problems with that? Why would we need to be aware of that? What'd you say?
And you guys don't move as they should.
Sure, absolutely. Why? Why is her? You don't have to. If you don't want to, you don't have to answer. But why are they not moving like my gut right now? Because why? Okay, parasol. You're absolutely right. You're totally on the right track. But again, why? Why is the peristalsis low? Is it just because they're in the ICU? Okay, so they're not getting up. That's a contributing factor. What else? What? Are they not eating?
Well, they might be.
Okay.
We don't know.
Okay, so we don't know, but I think that we can anticipate that we need to feed them, right? Not the way they're not having like what is it I was gonna say? In-N-Out burger, Big Mac. That's what I was gonna say. Big Mac. They're not gonna have a Big Mac. Okay, but they are gonna have 2 feeds, 100%. We are gonna be feeding them. But why else? Think back to the drips that patient is on. Okay, what medication? Okay, possibly the propofol, but more so than that. What's the other drip that they're on? Paralytic can contribute to it, but before that, before I started the paralytic. Opioids, right? Didn't you guys learn that, like in Block 2, when you first started getting pharmacology? Anytime someone is on an opioid, you need to be worried about constipation. Okay, well, what's the big deal, Professor Bloor? Constipation, it's fine. You can perf your bowel. You can get dead gut. You can get toxic colon. There's lots of things that can go wrong. So part of this is making sure your patient poops. Okay, part of this is making sure. Because we know that 3 of the drips that they're on are totally going to be slowing stuff down. Okay, they can get an ileus, where peristalsis is not moving. Okay, so they need to be on what? What kinds of drugs?
Stool softeners.
Okay, stool softener. Throw out a name. Senna, Docalax. Okay, great. DocuSys, right? But what is that going to do? It's going to soften it. Okay, but how do I make things move forward? Laxative. Okay, so just know that could be you. That could be you, where you need to advocate for that. Hey, I noticed that we just have like Senna and DocuSys, but they haven't pooped in 3 days. That's a problem. Okay. No, I do not want my patient pooping 5 times. Okay. I've had to ask a resident that before, where I'm like, do you poop 5 times in a day? No. Okay. Is that normal? Absolutely not. Would I like them to poop 1 or 2? Yes. Okay. So you might need a laxative. Oh, okay. So it's not working. Well, I tried my best. I gave the Senna and the Miralax. What else can you do? An enema. Yes. Pro tip, fleet enemas don't work. Okay? Get a Mayo enema. Those are the best. The Mayo enema, you can always make someone poop. Okay? It is your job as the ICU nurse, or any nurse, is to make sure your patient is pooping. Okay? It's like the Maslow's hierarchies. Okay? Feed, poop, pee. All of those things you need to make sure your patient's doing. Okay? Because they're not able to talk to you and tell you that. And you definitely do not want them constipated. Absolutely not. Okay? That can cause a whole host of problems. So we talked about skin. We talked about pooping. Okay? What else? What other things do you think need to be happening? If they're totally susceptible to the environment, what other things do you think?
Even just self-care needs.
Okay, so what does that mean when you say self-care needs?
Like, even just brushing their hair for them and brushing their teeth.
So how about oral care? Okay? Oral care is so important, especially when they're intubated. Okay? You have a direct conduit to someone's lungs. Okay? Everyone's mouth, yours, mine, the patient's, are very dirty. Okay? Very, very dirty. There's a lot of bacterial flora in here, and you don't want that going to the lungs. You want to prevent that. So oral care, oftentimes it's the chlorhexidine, like mouthwash type stuff, and you're doing that chlorhexidine once a day, but you're doing oral care Q2. Okay, when they're intubated and paralyzed, they're not doing that, so you're doing that for them. Okay, so oral care. Okay, what else? What else? What do you think? Are they still at risk for aspiration?
Yeah.
Okay, so how can we prevent that? Yes, keep the head of the bed up, so at least 30 degrees, right? Absolutely. Okay, so head of the bed. What else can you give them? What?
Give them a blanket. Could be cold.
Okay, so making sure that they're totally susceptible to the environment, so checking your temperature, I love it, okay, or taking off the 500 blankets the family members added, okay, because they thought the patient was cold and they're actually febrile, okay. Talked about oral care, we talked about skin breakdown. I see immobility up there, so they're certainly not getting up and walking around the unit, right? So we're worried about immobility, so what can you do to combat that? What types of things can you do? Passive range of motion. This is a lost art, you guys. We need to be doing this for our patients, okay? I do not advise people to be sitting at the side of the bed and dangling their intubated, sedated, paralyzed patient, but you 100% can doing passive range of motion, making sure they don't get stiff, okay? Work those muscles. I see that immobility increases clot risk. They are at risk for DVTs, absolutely. They are not getting up and walking around the unit. So what can you give? What can you anticipate giving?
SCDs.
Okay, SCDs, I love it. What about a medication? Okay, heparin. What kind of heparin? Are you starting a drip? Okay, so you're doing it sub-Q. Okay, sub-Q injection. 5,000 units per 8 hours, right? Sub-Q injection. Okay, excellent. So again, we want to prevent that. We see that they're at risk for this. right? We see that they're a risk for this, so you need to make sure you're doing this. What about their eyes? If they are paralyzed, are they blinking? Okay, so what should you maybe anticipate doing? Eye drops or lubricant, okay? We had an ECMO patient years ago who was very, very sick, significant ARDS, and he was intubated, sedated, paralyzed, very, very sick on ECMO, and nobody was doing eye drops or lubricant, okay? So when he woke up, okay, he survived all that, he said he couldn't see. And we're like, oh my gosh, what happened? He had significant corneal abrasions because there was no movement, no blinking, no lubrication in his eyes, okay? So can you imagine surviving that horrible episode and then not being able to see? How scary is that? So that was our mistake, okay? That was our mistake as clinicians. We should have been advocating for that, okay? Was it the doctor's fault? Yeah. Was it our fault as nurses? Absolutely. Was it the pharmacist's fault? Absolutely. Okay, anytime you see a paralytic on your MAR, you should be anticipating and advocating for eye drops, okay? We put them at risk for so many things that should never have happened, okay? He should not have had significant corneal abrasions. So again, they're at risk, okay? They're at risk, and we need to make sure we're protecting them from the environment, okay? And then feeding them. Are they eating their In-N-Out burger and french fries and shake? No. So we need to make sure that we're feeding them appropriately, okay? One of the themes of this is that tube feeds are king over TPN. TPN has its uses, but tube feeds are what you should be advocating for, okay? How are we giving the tube feeds? Are we pouring it down the throat and hoping for the best? What? So PEG tube is pretty long term, guys. PEG tube is someone that's probably going to be trached. Okay, what would be something that's not long term? Absolutely. NG tube or OG tube. So nasogastric through the nose to the stomach, or oral gastric through the mouth to the stomach. Okay. What do you think is better for aspiration? So an NG tube, okay, an NG tube, there's different lumens, okay, and different uses. I'm sure you've heard this, right? There's a lot, of course, there's like 500 million names for whatever. So we have a bigger lumen, right? A nasogastric lumen can be used for different purposes, okay? You can give food or medication through it. And then the bigger lumen, you can also what's called decompress the stomach. That means you're sucking out the contents of the stomach, okay? A smaller tube called a duo tube or Dobhoff is a smaller lumen. Usually it's yellow in color. Okay, yes, you can get an NG tube post-pyloric beyond the stomach, okay, but a duo tube is easier to do that because it's a smaller lumen, okay, and there's a wire in it that can help guide it to being beyond the stomach. Now, in terms of aspiration, do you think something that's a tube sitting in the stomach feeding it or beyond the stomach will help prevent aspiration? What do you think? What did you say? Beyond. So something that's post-pyloric, beyond the stomach, is going to help prevent aspiration, okay? And so in these kinds of people, oftentimes they want a feeding tube, a duo tube, post-pyloric, okay? Because even though they're not awake, these people can throw up. I've seen it. Where all of a sudden you walk in and it's just like coming out of their mouth and you're like, oh my gosh, where's my yonker? It's not a great thing, right? You want to prevent that, okay? Questions about this? Oh, I almost forgot. What lab would you want to get for a paralytic? What lab's important to make sure you check before starting a paralytic? What do you think? Huh? Possibly. I think that's good thinking. To see like how your drug's going to be metabolized. Sure. What else? What did you say? Anti-TNA?
No,
Hemoglobin? Well, maybe. But what do you think affects a paralytic? Everybody remember? No? Electrolytes, yes. So low K levels, okay? Low potassium levels are going to potentiate the effects of the paralytic. So you need to make sure you're setting a CMP. send those electrolytes because you don't want to make your paralytic, you don't want to potentiate it. Okay, it's important. Succinylcholine also drives up the K too. So you don't want to say, oh, we're going to intubate this patient. Can you grab 40 milligrams of butamate and I don't even know what the dose of succinylcholine, to be honest. It's 70 milligrams of succinylcholine, for example. We just never use it. You want to make sure you tell your provider, hey, my K is 5.7. Okay, because you don't want your K to be 7, right? You don't want your patient to code because they're hyperkalemic. So just know that succinylcholine, you do not give that when your K is high. And if you have low potassium levels, it can potentiate the effect of your paralytic. Okay, does that make sense?
Yep.
So it's important to check a CMP. Questions about this? Okay, so someone asked, right? How do you know that you're paralyzed? Are you just guessing and looking at the patient, just hoping for the best? Absolutely not. You are using a train of 4, okay? You are using what's called a peripheral nerve stimulator, okay? I have a lovely video that shows this, okay? So what you do, it's this like little pack, it looks like a little battery pack, and it's the peripheral nerve stimulator, okay? And you figure out how many milliamps you use, okay, at the lowest setting. And what you're using is you're trying to figure out what your baseline of your milliamps are, okay? If you have the opportunity to do this at clinical, please do. I will try to borrow one, or just take it and return it. I will return it, but just so you can feel what it feels like. It does kind of hurt, to be honest. Like, I was trying to figure out if this one was broken. I put it on myself, and it kind of hurt, to be honest. So just know that, lowest milliamps wins the thing. You don't want to hurt your patient. And so you are looking to see when you get 4 twitches, okay? There's several different areas of the body that you can put this. And there's 2 electrodes you're putting on the patient. Okay, it's going to make sense when you watch your video. But the most common is going to be your radial. And so what you're looking for is you're putting your 2 electrodes here, and you're looking for the thumb to twitch. Okay? So low milliamps, I'm seeing 4 twitches. Okay? Train of 4, right? That's where you're getting your 4 twitches. Now, right port is also always closest to the heart. Okay, so you'll see that in the video. Another place I've seen it is you can put it at the outer canthus of your eye, and you look for the eyebrow to move. Okay? Sometimes people put it on the ankle, and you can see your big toe move. Please know, just like anything, right? If you are delivering electricity to your tissue, any sort of edema can affect it, okay? So where are the places that get the most edema? Your arms and your wrists and your feet, okay? So sometimes it's important maybe just to do it here so you can see the eyebrow move, because this, unless you blew them up somehow, usually doesn't get edema, right? But just know that edema can 100% affect the train of 4. Okay, so the point of this, right? Why am I yammering on about this? This is going to help me be able to titrate my paralytic. It's you. You are the one that is titrating the paralytic. The physician is not coming by and titrating it for you. You're doing that. That is within your scope of practice. How you're titrating it is from this train of 4. So you need to get a baseline. So let's say at 5 milliamps, I put it on my radial, I got 4 twitches, okay? Once I start my paralytic, I recheck in an hour, and I see if I get, my goal usually is 2 twitches, 2 to 1 twitches. It'll be in your order, okay? And what that tells me is that I'm paralyzed adequately, okay? Now, let's say that I started my drip, my Nimbex, okay, Cystocurium. I made sure my patient is adequately sedated, we got oral care, I'm turning them, we got some lubricant on their eyes, we are doing great. I'm prepared for this, okay? I know they're adequately sedated, and they have a definitive airway, okay? So check. And I got my baseline, 5 milliamps, okay? And I started my paralytic. I should come back in an hour, and I still have 4 twitches. What does that mean? It's not working, right? It's not working. I gotta go up. Okay, so I titrate up. Okay. I go back in another hour and I check my twitches and I get 3. Okay, my goal's 2. So what does that mean? Go up. Excellent. Okay. I go in the next hour and I'm like, yes, this is gonna be it. I'm gonna find my level. It's gonna be great. I go in, I get 0 twitches. It's too much. I gotta go down. Okay. This is called the dance. Paralytic dance. You guys, it happens all the time. I'll be honest, I hate the train of 4. I hate it because I think that it's a recipe for a mistake because you're titrating it every hour. Okay? Because people's metabolisms are different. So I always advocate, to be honest, to titrate to vent compliance. Again, depends on why you're using the paralytic. Okay, but that's usually what I advocate for because I don't like this dance. But you have to go off of orders. Some physicians are like tried and true. They want this train to 4. So this is what you're titrating off of. Okay, and it's an hourly check. Okay, just like your vitals, Q1 hour. This is hourly. Okay, you're checking it hourly to make sure that you're at the appropriate dose. Questions about that? We're gonna watch this video. Well, look it, just got it on the outer campus of her eye in surgery. This this person's voice is very weird. Okay, it sounds like a robot. So just ignore that, but it still has good information. What's happening?
Blocking agents make a variety of life-saving procedures possible. However, these agents can be lethal unless appropriate ventilation is provided and the use of a peripheral nerve stimulator at a minimum or a monitor whenever possible to guide administration of blocking.
Okay, so let me get rid of this so you can see it. So this we're using, this is in surgery, just so you know. So, CRNAs and anesthesiologists use this. So you have 2 electrodes here, okay? Red one closest to the heart, right? So it's here, closest to the heart, okay? And so you have this and you're looking for this movement here, okay? So watch it.